Hi, I'm Luke Doles from the New York eHealth Collaborative, NYEC, or NICE for short. We are a contractor to the New York State Department of Health and oversee the State Health Information Network for New York, or the SHINY. The SHINY consists of multiple RIOs for health information exchange. These RIOs are independent and utilize various technologies to support their regional HIE initiatives. We have implemented the IHE Cross-Community Access, or XCA, for exchange of documents between the RIOs. This was primarily for a RIO participant or provider to view a patient summary document from another RIO in the clinical viewer. This exchange of documents is limited in its use and can be cumbersome for the user because they may have to retrieve and view multiple documents, one from each RIO, that contains a patient's clinical data. The IHE XCA project began about 6 years ago and involved all the RIOs. Even though vendors were able to generate the on-demand document, the CCD or the CCDA, all transactions had to be configured and tested across all RIOs. XCA uses 3 different SOAP transactions to retrieve a document: patient discovery, the XCPD, then the XCA query to get the repository ID and the document ID, and then the XCA retrieve to retrieve the on-demand document. Also included with all these transactions is the signed SAML for audit, and obviously security for transaction transmission. NICE developed an orchestration hub and record locator service, basically a master patient index, to support the information exchange across the RIOs. The functionality of the hub is the first to provide other RIOs that have records for a particular patient to the requesting RIO. Then a document query is sent to the hub, and the hub distributes the query to the other RIOs and consolidates into one response. Then the requesting RIO sends the document retrieve transaction for each of the document IDs. This initiative began in the second quarter of 2014, was not live until the beginning of the fourth quarter of 2015, nearly 18 months of design, development, testing, and implementation. Because of the architecture, all aspects of this implementation had to go live at the same time. Since the initial implementation, there have been a number of issues identified that can cause failures in retrieving the documents. This can be technical issues with one or more RIOs, a SOAP message formatting issue, and even basic communication issues. The size of the documents could also be an issue because the RIOs have up to 10 years of clinical data, and this can cause timeout issues. Another factor is the on-demand document generation can be fairly resource-intensive process. We do weekly production testing with all the RIOs, and it is rare that the document exchange is 100% successful. Some RIOs wanted to use the specific discrete data from documents retrieved. Though the documents contain the discrete data, the entire document needs to be retrieved, then parsed to get the specific data. This is done for patient cohorts and reported back to care management organizations for specific lab values and vital signs. This is a very cumbersome process. Last summer, we took on a project to build a FHIR framework across the RIOs. This involved each RIO setting up a FHIR endpoint. This would allow the same functionality as retrieving a document and parsing for discrete data, except with a much lighter weight transactions and hopefully with greater reliability. The centralized service was also a much simpler implementation, communicating system to system and generating the JSON web token to contain audit information. And this was following the IHE Internet User Authorization specification. This is similar to the SAML in the XCA transactions. We would still retrieve the data centrally utilizing the record locator service and then aggregate the FHIR responses into a single bundle per patient. Some RIOs leveraged their HIE vendor for FHIR, but some had to do development from scratch. The FHIR resources were created pulling the specific data from the RIO's clinical data repository. The primary use case was to retrieve discrete data for a patient cohort, such as the last A1C lab result, or vital signs such as blood pressure. For this use case, we limited the required FHIR resources to patient, condition, and observation. The initial FHIR framework was in production in about 8 months compared to the 18 months required for the IHE XCA implementation. The limited implementation allowed us to get the FHIR endpoints in place and provide a mechanism for the initial use case. Unfortunately, we have not been able to fully execute the initial use case because of demands for data from the RIOs to help with the COVID-19 research and reporting. The FHIR framework was not quite ready to address pulling FHIR resources for this support. Now we're planning to build on the initial FHIR framework over the next year to support these public health use cases for things like COVID-19 reporting and flu surveillance. This will be a centralized pool of data that will be aggregated and delivered to the DOH for public health. Eventually, we want to enable RIOs to be able to do specific patient queries from their HIE through the centralized services and receive the specific FHIR response resources. This will give the RIOs the greatest flexibility to utilize the FHIR framework for their own initiatives and possibly integrate into the clinical viewers. Currently, most of the RIO implementations are using STU3, but we're putting together plans to get all the RIOs to version 4. Even though this was a limited implementation for FHIR, it was a proof of concept for a simple FHIR implementation that can be incrementally expanded to provide more functionality across the Shiny. Thank you.